My name is Sam Youssef. I'm one of the heart surgeons here. We are a group of 5 heart surgeons, and this is my 8th year of practice in cardiac surgery. And so when I reflect on your time, where we were, high school year, senior year, you've got all your electives done, you've got basically a first quarter of grades to get in. I think that gets included in your GPA calculation maybe. You've done your extracurriculars, you've done your research, you've done all that stuff. That's exciting. Now you're figuring out where are you going to go and what are you going to major in. So you kind of have an idea that you're interested in health sciences. Everybody here interested in health sciences? Dentistry, pharmacy, surgery? No? Where are you interested in?
Computational biology.
Computational biology. What does that mean?
It's interdisciplinary. Oh.
Hey, here's the mic. Yeah, that's right.
It's interdisciplinary between statistics, computer science, and biology.
Okay.
And I plan on hopefully predicting protein design or designing de novo protein structures.
That's awesome. Very cool. Very cool. So even though you may be creating a new leaf of corn that is resistant to a certain poison of a bug that will produce extra corn and genetically modified in an underdeveloped country, that is definitely biology. It impacts life. So one of my guys at UCLA was doing when I was an undergrad. That was his project, and it blew me away just from the way that he was understanding the big picture to the small picture. So when you're doing anatomy boot camp, that's what you're doing. You're taking a blueprint of life, and you are seeing how it became life, became the human body. Anatomy is what's going to blow you away. The physiology, the genetics, and all that, excellent. But anatomy, for some reason, and if you're right-brained, you like arts and crafts, this is definitely your field. You know, in the way that you move along your development into science and development into medicine or into dentistry or into surgery, whichever way it's going to go. And the way you like to think about it is sometimes you have a blueprint of how you're going to create something or how you're going to see something modify. And when you see how that blueprint, an expression of proteins, an expression of an organ, the organ becoming a system, multiple systems coming together to be a human body, and then you see all of us in here carrying that same pathway to fruition, it's pretty amazing any of us turn out normal or quasi-normal from what we think. What's your favorite system so far? Just yell it out.
Immune system.
Immune, okay. Endocrine, all right. Who else? Come on, look at my badge. What am I doing? I'm a cardiac guy. Anybody like the heart? Anybody like the lungs? The gut? The guts are kind of okay. How about the spine? Kind of cool. What about the heart? It's fascinating. Come on, guys. You know how biased we are to what we're going to do. So I'm going to share with you a little bit about the heart today. And before I get in, jump into anatomy, it's just if you guys had any questions right off the bat about life stuff. You're all here to learn something that's going to give you an enriched understanding. When you go to college, you may look back on this course and say, oh man, I saw the thymus gland in the mediastinum, rock on your biology. Or you're going to learn how T cells develop and B cells develop and know where they land and why that happens. Those I just turn this thing off. I hate mics. It's on again? Okay. Wrong button. Okay. I work with markers, and then we're going to jump to the lab. We'll show you some stuff, but I didn't have any PowerPoints or anything like that, because if you can conceptualize the way that blood flows through the heart, and we start with the heart and then go out from there, we'll be able to cover everything that's in the mediastinum and the thorax. So, 55-year-old male, gangbanger, South Central LA next to USC. East versus West or Crips and Bloods or whatever it is, gets shot through the chest, right here. What's the course? Actually, no, let's go from here. Let's go from left side. And it angles like this. What is the course of that bullet going to hit as it goes through to its exit site, which is right here? And how do you know if you're going to be able to save him or not? First tissue, surface. What are you going to hit?
Skin.
Skin, muscle, bone. Okay. Now you're in the lung space. Left side lung has how many lobes? Anybody know? 2 lobes. Upper and a lower. Right side has 3. Upper, middle, lower. So we've got an upper lobe, most likely that bullet's going to track right through. All right, now you've gone through the lung. And as you get to the lung, there's going to be another structure that's going to be right here. Anterior is going to be what? The heart. Behind the heart is going to be what? The aorta as it goes down, descending aorta. What else? The diaphragm is going to be right at that area. Behind the heart is going to be esophagus and vena cava. And the trachea is a little bit higher, but yes, that would be back. In anatomy, you're going to learn a lot of mnemonics. And first year medical, I still remember the mnemonics. Who knows the mnemonic for what crosses the diaphragm at what level? I ate 10 eggs at 12. IVC is at T8. Esophagus, 10. IVC, 12. That's how you know by a thoracic vertebrae. So if you're looking at an x-ray and you're looking for where you are, where is the projection of this course going to come in? You're going to keep that going across. So now you know IVC, esophagus, and aorta are going to be right here. And then as this thing comes out and you're crossing the diaphragm, what's the big structure that's right underneath the diaphragm on this side? Liver. So if you have a gunshot wound coming through chest, through the heart, out the liver, you better pray you're in a level 1 trauma center and you can take care of this guy. Because you have to fix the lung, you have to repair the heart, and you have to pack up the liver and make sure that anything else that thing is blown through is going through. The chance of this guy surviving are slim. But if he's in somebody whose hands of someone who went to anatomy boot camp in Seattle in 2019, that kid's going to survive, right?
Yeah.
All right. C345 innervates your phrenic nerve. Phrenic nerve innervates the diaphragm. 345, stay alive, right? I'm going to throw out some things that I remember, and I have not reviewed my anatomy notes, but these are some of the mnemonics that you come up with, how you're going to remember stuff, because there's such a huge amount of information that's going to be thrown at you in anatomy when you're studying it like this from the first time. And how you clump information together, doing it by organ systems is extremely important, but then seeing how those systems relate to each other, that's a big deal as well. So, the first thing that you notice about the midline of your chest is that it looks like a tie, right? You have a bone. Can you guys see if I draw here? I'll start here with the surface anatomy and then we'll go. So if you have, my mom would be so pissed off if she saw me do this at home. Okay, clavicle, ribs, xiphoid, and ribs come out. When I take a resident through a cardiac operation, I say, you have to feel where the costal margin is here. You feel the xiphoid process. You feel the sternal notch. You feel this process. And when you grab your saw and you open this guy's chest to get in to do surgery, which is what we were doing this morning, you have to stay midline. So you're noticing the spaces that are in between here, in between here. So this resident is going to take his saw and he's going to come straight up the middle and end here, and we're all going to be really happy because he stayed right in the middle. Now, what if this resident doesn't do that? What if he was falling asleep after lunch in his anatomy boot camp class and he forgot where the different things are? Coming up and down inside the chest, and I'll come to this in a second because we're going to look at inside. It's still an artery, but I'm just going to put it in green for the sake of anatomy. You know that the heart sits right here, okay? And the heart gives off branches, and each of those branches goes to start supplying something. So you're going to have the aorta coming up from here, and off of the aorta come the coronary arteries. And the coronary arteries, we'll talk about them in a pattern, but on the left side, there's two. One is a left anterior descending, the other one is over here, which is the circumflex. And on the right side, there's one, the circumflex. We'll talk about different branches later, but that's the first branch of arteries that come off of the heart, right here. The aorta is behind it, but the aorta is right behind the sternum. So if it goes too deep, what happens? Bad day, right? So you got to keep your sternum nice and high, and you got to feel it behind. But you usually have a layer of pericardium over it that you'll be able to protect from your saw, but it's just tissue. So if you're totally out there and you don't know how to use your saw, that's going to be a problem. The branches then that come up here go along then to feed your brain and your arms. And the reason why I'm superimposing this on the clavicle here is because it's going to be important for your relational anatomy for what you see. And then the descending aorta comes down here, crosses over, and then you get your femoral arteries and vein. Excuse me a second. Hey, make a phone call. I'll be right back. Excuse me. Hi, Donna. Youssef here. Hernandez was paging me. He needs me now, or is he okay? I'm in the middle of giving a lecture.
Oof.
Mess this up? There you go. Okay. So we were walking through that resonant going through the sternum, but now we're talking about where are the things that are relational to it. And we're talking about, here's the arteries that come down here. One of the arteries that we love as surgeons is this one that comes off of the first branch of the left subclavian. Right? So the terminology of this is the ascending aorta. Ascending aorta. This is what they call the innominate artery. I don't know why somebody called it that. It just has no name. It's not called the right innominate. It's called not the brachiocephalic. It's called the innominate. But the innominate ends up breaking off into the right carotid and the right subclavian. And then, of course, if there's a right carotid, there's going to be a left carotid. Great, you did well in your SATs. Okay, and if there's a left or if there's a right subclavian, there's going to be a Left subclavian. So left subclavian comes here. So you have blood coming up from here and then going to all this network up and then coming down. This artery that's on the inside of the chest wall, this is the reason why cardiac surgery took off in the last 20, 30 years. As you can see, this artery is coming down inside the chest wall and continues down all the way this way. The same with this one, the first branch of the right subclavian coming down. These are called the internal mammary arteries. Anybody have a guess as to why the internal mammary artery is important? What would a surgeon use it for? So you know, like when you give your kids Legos, you tell one kid to build a truck, you tell the other kid to build a plane, all of a sudden they mix their Legos and you have something that's a mix of both. In surgery, it's kind of the same. You take an anatomy of something else where this is going down. This is supposed to be going to the chest wall. So this is a chest wall artery. And some brilliant surgeon who was sitting in an anatomy class like this said, hey, that's pretty close to the heart. And this thing here that's just kind of pedicled with little small branches into the chest wall is actually a 3-millimeter hose going down the chest wall. So you can imagine if someone is suffering a massive heart attack, or not massive, or chronic, and has a blockage in these arteries that are feeding the heart, some genius surgeon who was sitting in anatomy boot camp in 1972 said, why don't we just clip off the branches of this artery here from going to the chest wall, take this as a whopping hose, cut it off here, and then on this artery, if this is one of the arteries, and this is your mammary artery coming from the chest wall, and there's a blockage here, and you want blood to continue going down, why don't we open this artery up here and fillet this from here and suture this way and create what we call an anastomosis, or a connection between the ability to have blood where your heart is starving for blood and the ability to take blood where your body has plenty of it, and understand from embryology that they come from the same sources, and you'll learn this when you get further into anatomy, and take the artery from the chest wall and stick it down on the heart. And this goes away. This is what a coronary artery bypass graft is. This is what we do for patients who have had heart attacks, or patients who have coronary disease, or patients who have a buildup of plaque, that the heart function, boom, 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 starts to decrease because the heart has no fuel. The fuel line is blocked. Man, this is reconstructive. We're not coring something out. We're not really taking out a cancer or a tumor or doing that, talking about heart surgery. We're replumbing this. Well, what if we do the same from the right side? Well, we can do that. Let's take this side and let's clip it from all the branches that are going to feed the chest wall, and let's create an anastomosis over here that same way. And now blood, which is supposed to be coming down this way on each of the arteries, and is suffering from a blockage here, once you open these two up, you have a double bypass. Boom. You're supplying a ton of blood flow to that heart. How do you think that heart muscle is going to react? Be happy or sad? Happy, like really happy. And so when you're coming off the heart-lung machine, you're like, wow, this is awesome. You take a heart that was barely squeezing, all of a sudden you just do a bunch of suturing on it, you do all this, replumbing. Now that heart is squeezing really, really well. So somebody was paying attention in anatomy class. Because this is an artery going to here, and this is an artery going to here. The other option, we take a vein from the leg, or we take an artery from the arm, we create a bridge, and we do it that way. So that's how we complete the bypasses if they need more than just those two. Does that make sense? What's the name of this? Internal mammary artery. Left side. left internal mammary artery. This artery here on the heart is called the left anterior descending, LAD. So what you hear us say, oh yes, we're preparing for cabbage today. Today is 15th of whatever day, and we are doing a lima to LAD, or lima, left internal mammary artery to LAD. And we're doing a saphenous vein graft to the right, okay? Or we're doing a rima, right internal mammary artery to the right. Or we're doing an artery from the arm. That's how we are using the natural anatomy to augment function. Structure and function are interrelated big time. This makes sense. So this resident who was careless, not all of them are, and this is only a hypothetical resident because all residents are perfect. The hypothetical resident came in with this saw and then he got scared because there was a big sonic boom, something happened and he went this way. And what artery are we in danger of violating on the chest wall? The left internal mammary artery is here. But thankfully he was superficial so he didn't lacerate the heart. But we just talked about a really crazy case with the bullet that came through. What am I drawing here? Diaphragm. So that bullet went through this guy's chest wall from here, okay? So we have lungs we have to talk about first. Left upper lobe, left lower lobe. Pretty easy, and a fissure in between. Right side has three. Right upper lobe, right lower lobe, and right middle lobe. These lungs serve a huge purpose, which is what? The obtaining of oxygen and the exchange of CO2, right? So that interface that happens at the micro level, that's important. But on the big structure level, for a heart surgeon, the lungs are just pillows that rest the heart. You know, they're just there. But for a lung surgeon, this is what they do all day. What happens with this bullet wound is that it's going to come through and track along here. So this left upper lobe has to come out. How are we going to do that? Every lobe of the heart or the lung is being supplied by an airway, an artery, and a vein. Every lobe. So we have to look at the anatomy of that. We'll get to that in a second. Then this bullet wound comes in, and you know what? It hits the left ventricle, but it just barely skives it. So there's a bruise, but it didn't enter the cavity. Here, I'm going to change the trajectory this way. Otherwise, he's probably going to be dead. And we want to actually do something for this guy. So that bullet then grazes off here, but it hits a big structure right here. What is this? This is the inferior vena cava. So this is the inferior vena cava that came around, and this is now behind the liver. Okay? So a lot of bleeding is going on here, but it's venous, so low pressure system, and it gets encased kind of within the fascia of the liver. And so we have to see, okay, we might have to get to this, but I'm going to teach you a pretty cool anatomy trick here in a second, surgical anatomy trick. And then it comes through the liver, and it goes through here, and of course the liver has blood supply and everything there. But the bullet comes out. In the liver, thankfully no major damage. All right? So the surgeon's going to open up the belly, he's going to pack that around. The heart, he's already opened up the chest right here. Everything is basically filleted open. We have to take out the lung, we have to fix the heart here with some stitches, and then we got to do something about this inferior vena cava. These are heart injuries. This is anatomy that's traversing many chambers, many cavities. And the reason why I threw out a really kind of theoretical surgical case to you is because it's, you know, think about this as systems that are interacting. You may need to use a heart-lung machine. And if you use a heart-lung machine, you're basically drawing off all the blood from here and sending that to the pump. And then the pump is going to send it back to you. And I'll talk about that in a second. That's very specialized cardiac surgery. It goes beyond just anatomy. But if you're in rural North Dakota and you have no heart-lung machine or something, and you have to get to, not that I'm saying they don't, they probably do. If you need to get to this, and this is the anatomy you're faced with, you have to know what leads to where. So we talked about the heart. We talked mainly about the aorta interaction with the heart. I'll move over to that side. We'll talk a little bit about kind of the internal anatomy of the heart so we can understand where the pulmonary arteries are veins. You had a question?
Yeah. I was just curious, when you're saying you're taking the left internal mammary artery off the chest wall, like what happens to the rest of it? Like what happens to the tissue that it was supplying?
Very good question. So most organs have a redundancy of blood supplies, so 4 or 5. So if you take one away, they have 3 or 4 still supplying, and they will revascularize accordingly. So it becomes this network of blood that then takes there. It's a very good question, because if you don't have it, so say for example the arm. The arm has 2 arteries, a radial artery and an ulnar artery. And we want to use this arm artery for bypass. We have to make sure that they collateralize in the palm, so that the palm is fed by both the radial and the ulnar. We look for what we call a palmar arch. And if that arch is complete, it means we have a redundancy of blood flow. So if we took the right radial artery, if we took the radial artery in the left hand, the ulnar artery will take over the function of the arm. If you don't have an arch that's complete, just to take this analogy one step further, and you take this radial artery, you can have dysfunction in the arm because those vessels won't have a major blood supply. So in order to do this type, you have to make sure that what you take, you can deliver and go back. Does that make sense? You guys are okay with this drawing stuff? Is all right?
Can I ask another question?
Yeah, go ahead. Yeah.
And then how do you, like, I'm assuming when the bullet hits the heart, like what happens to like the pericardial sac? Does it like just burst?
It can fill with blood.
But is it, I guess, elastic enough to, like, does it burst when something hits it, or?
Let's go through that. So in embryology, you first start out with 3 little buds, 1, 2, and 3. And each of them are formed within a specific sac. The sac of the heart is one, the sac of the right lung, the sac of the other. There's fluid in that sac. So there's fluid between the part of the sac that is up against the chest wall and the part of the sac of the balloon that's on the tissue itself. And fluid fills that space. If fluid is able to fill that space, it acts as a cushion. But the heart, as you can imagine, is fixed. This is, say, left side, the left ventricle as you look at it, and the pericardium is here. And there's usually just a very thin space. And you see that bullet wound come in. It doesn't go through the heart, but it just kind of grazes the muscle. It can create a buildup of blood in this space that will stretch out the sac. But what's going to compress first? Will it keep expanding out, or will it start to compress on the heart? What do you think physiologically? It'll start to compress on the heart. That's what we call cardiac tamponade. So you have to open the sac and release this blood, but you have to be ready to say, you don't know if that bullet wound went through and through the ventricle. Then the likelihood of you being able to, you have to repair it. You have to, all right, you want to know something cool? This is how we would do this. Take a Foley catheter, you usually stick in, it has a balloon on one side. If you see where the hole of the trajectory is, you stick that catheter into that hole, you inflate the balloon, and you stop the blood from coming out. So that will buy you time to be able to fix it. Or somebody just has to put their finger over it. But if you put your finger over it, it's a lot of raw tissue. Down here, same thing. You have the exit wound, you could stick a balloon into there. You can do that. This is trauma locker room talk. Nobody really does this, but this is what they say you can do. We've seen it, and I've had to do it once. Where you have a traumatic injury to this, whether it's from something coming from out or something coming from within. A catheter in the heart or something that goes out, can happen. And then you just have to close that wound there, but you have to relieve the pressure here because this pressure is going to do what? It's going to push on the heart. I'm trying to give you anatomy that's applied. When you go through your training, whether it's going to be here or med school or dental school, whatever, some are going to give you the classic not Gray's anatomy, but the Netter anatomy type of introduction. And you may have seen that matter maybe today. You may go through it. We're going to have, and this nerve courses over here, and this artery bifurcates, and you're going to have that, and you need to know that cold. But sometimes you need to know what is applied anatomy. Where does the pericardium lie in comparison to the heart? And we'll see this when we go next door. We'll get an appreciation for that sac, because if that sac fills with space, that's a problem. And it will fill with space not just in a bullet wound, but in end-stage lung cancer. So you may have somebody who has end-stage lung cancer, and all of a sudden they can't breathe. Well, it's not because of their lung, it's because this sac is filling up with fluid. Cancer cells, cancer fluid. If you don't do anything, they're going to die within days. If you're able to drain that fluid, even though you're not treating the cancer, you can at least relieve them symptomatic. So applied anatomy is important, where you can see how things kind of work. We'll get to the anatomy of the lung, and we'll get to the anatomy of each of the lobes, so you can see kind of what happens when we go through the intracardiac structure there. Any other questions on this? Does the guy survive? Why did he survive? We got to him soon enough, good. And what were we able to do? So what did we do for him? Repair the lung, or we remove the lung, one of the two, so we can get rid of this. So it means we got control of the artery and the vein and the bronchus that this bullet wound went through. We got rid of it, so that's safe. We opened up the sac, we drained the blood that was there, we inspected the heart. We were so happy it didn't go through the heart, but we fixed the part that it grazed on here. Then we got to the IVC, and on the IVC, we just packed it. We said, all right, this is a low pressure system, we're just going to pack this. Sometimes it works, sometimes it doesn't. And in this case, in this where the bullet wound went in, we just packed the liver. And sometimes you just pack it and the blood around it just kind of solidifies. And he survived. Well done, guys. You took a crazy complicated trauma case and he's out. Just by 45 minutes of applied anatomy. So now we're going to go through something more predictable. Any questions on this? Okay. Falling asleep yet? Do you have coffee, or are you too young for coffee? You guys drink coffee? Yeah, that's what I thought. Okay. Here's the heart. For real this time. The blood comes into the heart from the IVC. And we just experienced that because here is a diaphragm, and this is where the bullet wound went through. We packed it here. All that blood is coming up here and coming into the first chamber of the heart. And that is called the right atrium. And from the right atrium comes the first valve, the tricuspid valve. Have you guys heard about this already? Or is this new?
I read the right stuff on the left side.
Okay. We'll go through both sides. So this is the right atrium, and this is the tricuspid valve. Why is this valve important? It's a backflow valve, so you want every valve that's in the heart to be a one-way valve. But if you walk along the I-5 corridor, or you're going up to the northern area, and we're having a problem in our parks because there's a lot of needles that are on the ground. A lot of needles are on the ground because people are injecting drugs. I'm not going to turn this into a don't do drugs scenario for you guys, but you all know that, you're smart enough and you're there. But when it comes full circle to your clinical practice is because the other branches that are feeding into this system, your azygos vein, your subclavian vein, the subclavian vein comes down to the arm vein comes down to the finger vein, and the needle goes in here. So if you're going to check and evaluate where the trajectory of crap is going to go, what's the first valve it's going to land on? Tricuspid valve. So on your board exam or an SAT exam or real life or emergency room, they say 28-year-old female injecting, coming in with a loud murmur in her heart, febrile, and lung pain or right-sided chest pain. The stuff comes up here, and it's all going to land in here. and it comes onto this tricuspid valve. I'm expressing this because this is the effect of drugs. We see a lot of endocarditis. We see a lot of brain stuff too, from people not being able to make it or not surviving to the point. But those who can survive and they haven't passed out from the mental depressive effect of the drugs, they have pretty significant intracardiac infections. Tricuspid valve comes into the right ventricle. And after the right ventricle, you come out to what's called the pulmonary valve. Okay? From the pulmonary valve, you're going to enter what we call the pulmonary artery. And the pulmonary artery is what's going to be the artery supply for the lungs. And you're going to learn this anatomy that you're going to have pulmonary artery, pulmonary vein. Well, pulmonary arteries we usually think of are what? Carry arterial blood. But is the blood in this PA going to be oxygenated or deoxygenated? Deoxygenated, because it's going to the lung. So it's all cardiocentric, right? Is it going away from the heart or to the heart? This is going away from the heart. So the pulmonary artery is going to the lungs. And as it's going to the lungs, it's going to give off branches of the upper lobe, and then the lower lobe branches, and then you have a subsect branch, and you have a lingular branch, you have a bunch of branches. You'll go through this in your anatomy. The same with this side. The pulmonary artery comes off, gives a bunch of branches, and that's in the lung, and the lung is kind of over here, over on this side. All right, now we've reached the lungs. The lungs are being able to be fed with this blue blood, right? All this is deoxygenated blood coming in through here, right ventricle, pulmonary artery, up and out. Once you reach the lungs, you get the exchange, capillary exchange. Oxygen is loaded on board, and carbon dioxide is delivered out from the lungs. So with each respiration, you can do that. So when we look at our anatomy, then we're going to look and see, okay, we're going to see this pulmonary artery, and this is pretty cool. So, another story. Some guy from Dubai, see that? Traveling on a long-haul flight, sitting in the chair, fell asleep watching Creed 2, and this is the femoral venous vein, has major DVTs and clots in his leg. The moment he stands up and he grabs his bag, and he's all the way in the back of economy class, it was taking him forever to get there. The moment he stands up, he collapses forward and turns blue. What's your differential diagnosis? Pulmonary embolism. Does anybody know what a pulmonary embolism is besides you? It's a major PE. Doesn't just not because it's from Dubai. Anybody who's coming off of a long haul flight will have this, right? So a clot forms with Verko's triad. What's Verko's triad? Anybody remember that? Stasis, hypercoagulability, dependency, right? So we've got vascular injury. So you have issues here in the leg causing a clot to form in a vein. The guy hasn't stood up, hasn't done his calf pump exercises. When he's in the flight, he comes up, he stands up, and this clot travels. And it travels and it looks like a sausage. It's like this. And it goes through his tricuspid valve. And then because it's just kind of floating like a tube down a river, it comes here and it lodges right here. All of this tube now is nearly occlusive of blood flow going down either side of the pulmonary arteries. This is a massive saddle PE. Sometimes this requires surgery to take out. So you have to go to the heart-lung machine, open this out, and take this out. It's a very gratifying operation, but sometimes the right ventricle now can't push anything forward. So you think this ventricle is going to be happy or sad? Sad. Why? Because he can't do what it needs to do. You're loading him with basically a 100-pound dumbbell and telling him go and do bicep curls 80 times in a row and don't take a break. This muscle has nowhere to go because it's completely obstructed. So the RV is not happy. What about the lungs? Are the lungs happy or sad? Sad. Why?
Because
they're not getting the blood. And they're not getting the blood to dump the oxygen onto it. So you have a hydraulic problem here because you don't have flow. And if you don't have flow, then nothing's going to continue going up and down. So you have to thin the blood, heparin is the first thing, or you have to lyse this clot with pretty powerful blood thinners, and that will allow this to open up. So somebody was standing by, they did CPR on the guy. By virtue of the CPR that they were doing, they actually are moving blood through, and some, big dude ended up pushing this clot out a little further so that blood could get around. What's the point of CPR? Cardiopulmonary resuscitation. What are you doing? You're pumping the heart. You're decompressing the heart. Good CPR means you are in the right position, you're understanding what's the possible things that you're doing, and you make sure you're decompressing the heart. So this right ventricle is not going to like being distended. And if this right ventricle distends, and you've got this, you're going to get into an arrhythmia, go into a cardiac arrest. The same is true for the left side for different reasons. So the CPR may help, it may not. Because if you cannot get this obstruction out, the chances of you saving that person are pretty low. But you still do CPR because you have no idea why he arrested. But this is why a PE happens, and this happens on the right side. All right, now the PE is cleared, we've done our surgery, everybody's happy, the lungs are getting their blood flow, and they start to come back to the heart. You guys okay? Yep. Lung gets the veins, and then you have the first chamber back here, which is going to give you your atrium. And then from the atrium comes the mitral valve. And then through here comes the aortic valve. I'm going to draw this over on this side here so you can see this a little bit better. And then the aorta as we described it before. So you can see the aortic valve and the pulmonary valve are kind of in the same range. They exist kind of at the same line. So we talked about this is the mitral valve. 52-year-old biker doing the Chili Hilly. Anybody heard of that? What's Chili Hilly? It's a long ride over in Bainbridge Island. They've done it in like February. It was a little bit cooler, but they go for long. Presents with sudden onset shortness of breath while biking really hard. Sudden onset shortness of breath. Cardiologist listens to him, billowing systolic murmur. Meaning every time the heart squeezes, blood's going the wrong way. Inside the left ventricle, there are these muscles that are attached to this mitral valve. That's how the system works. It's like a hot air balloon. Imagine, it's got the anchors that are down to the bottom. You have a balloon like this. You have all these chordae. You have a base down here. You see the little up cartoon, right? He's in the, one of these cuts, what happens? The whole thing starts to fall apart, right? Same with the mitral valve. One of these breaks off for some reason. This valve is going to prolapse. And this valve prolapsing is going to give you the sound of a murmur. It's give you the symptom of the shortness of breath. So your anatomy is directly related to his physiology. The anatomy is not right. His physiology is not going to be good. And neither is his clinical presence not going to be good. So mitral valve, when we see this, it's all going to be what's inside here. This is going to be prolapsing here. So instead of this shutting like a French door, we have this now billowing in the wind. So we have to go repair it. We take this cord, we reattach it down here and put a ring or something to stabilize the valve. If we can't fix it, we take it out and we replace it. That's the mitral valve. So we said right ventricle coming up, this is pulmonary arteries, but it has blue blood. The pulmonary veins are what are returning from the lung, going to the heart into the left atrium. And left atrium, across the mitral valve, up through the left ventricular outflow tract, and then up here to the aortic valve. Out of the aortic valve to the aorta, as we discussed before. Any questions?
You mentioned that it can put a reading and help the mitral valve.
Yep.
Does it make like stay there with them?
Stays for life, yeah. It becomes a prosthesis that you put in, it just stabilizes the valve. Usually that's if you have a valve that's degenerating because it's growing. And if it grows, then your leaflets aren't going to meet in the middle. Your leaflets have to meet in the middle. What that ring is basically like a belt. You bring that belt around and cinch it together. You can choose which size. So it gives you stable, it becomes a fulcrum so that each of these leaflets can work. So the leaflet can now have a fulcrum against which it can work. You can use this as your fulcrum, and now this leaflet can work. That's if you're doing a more kind of complex functional mitral regurgitation repair. This is a repair because this chordate ripped. Somebody totally normal, totally healthy, doing aggressive exercise. Last case. "32-year-old guy, Russian, goes to the gym. I only do Russian deadlift, only. Only. Maxes out Russian deadlift. I don't need to breathe, I'm fine, right? Does his Russian deadlift, all of a sudden, oh shit, chest pain, right? What's gonna happen? What does he have? Chest pain happening, young, normal, healthy guy, high pressure in the aorta. Any disease in the tissue can spark what we call an aortic dissection. Aortic dissection happens when there are 3 layers inside this: intima, media, adventitia. The high pressure, the valsalva, all that together puts a huge stasis of pressure inside this aorta. It ruptures. And when it ruptures, it goes between the layers. So if you have a normal tube and blood goes through one chamber, that's it. That's a normal tube. But if this tube is composed of 3 layers, and now you have a second channel, you have a false channel, a true lumen and a false lumen, then when you put blood down the false lumen, what's going to happen? It's going to push onto the true lumen. Basically, the aortic dissection is a tear in the lining of the aorta. It's an inner tube in your tire that's ruptured. And so the only thing that's barely containing any pressure on you, if it can, is the actual outer part of the tire. This is a catastrophe. This is a 10-hour operation, maybe less, maybe more, whole reconstruction of anything, and when it rips through the anatomy. So it may start here in the ascending aorta, continue into the arch, and then come into the descending aorta. This is a problem. This has to be fixed. This is a purely anatomical, this is plumbing, caused by a functional issue, but more functional issue meaning blood pressure issue and tissue issue. So the genetics that we were talking about before play hugely in this type of a thing. And is it, yes, my brother had same thing. Okay, well, you have a genetic predisposition, so you have some type of mutation in a gene that is responsible for the tissues of the aorta. In the presence of high pressure, high blood pressure, I don't take blood pressure med, and it has a high stimulated event or something like it can be a golf swing, it can be a sudden stressful event, it can be lifting blood pressure, lifting weights. So we'll see all these things when we go to the lab. When we go to the lab, you guys are going to change, you can do your thing. We're going to look at some of the ultrastructure of the heart, the valves of the heart. I want you guys to at least come away with that, and how things kind of interact. We'll look at the pulmonary arteries so you can imagine, okay, this is where the major PE goes. We'll look at the mitral valve, we're going to blow that out and make sure you can see what happens when one of the leaflets comes up. We're going to look at the coronary arteries on the surface of the heart. You can say, oh, that's where a massive heart attack would be. We'll look at the tricuspid valve and say, okay, this is where IV drug use endocarditis can come from. We'll go through all those different things on the heart and see how it looks. We'll look at the vessels, how they come through the diaphragm, how they come up from the SVC, and go from there. One anatomical trick only talked about in books and maybe board exams. I'm going to go back to that hepatic retrocaval injury. If you have a big tear here, and this is behind the liver, and you can't pack it, this is an anatomical, purely related just to anatomy. You may hear it here, you may never hear it again, but just to show you what to do, if you have to put a cannula, I may be going offline here, but I'm just telling you what to do. If you have a big bleed out from here, right? Say you have the same in an aorta, a big bleed out in the aorta for whatever reason. You can put a stent in here and stent this over. So all the blood's going to go through a stent. The vena cava is not as good for a stent because it's more pliable. And if you're in an emergency sometimes, what they'll do is they'll put a catheter that's yay wide and cover this area here. It's called a Schrock shunt. You're basically shunting the blood into this catheter and letting it come up here until this will stop around, and then you can take this out later on. So anatomy is the king. Surgery is in respect of anatomy. And surgical techniques are made to mimic and restore anatomy. This is what we do. So heart surgeons, this is what we do. We fix these things. We're plumbers, basically. And we take care of different parts of the heart and lung and aorta. So some of it's vascular surgery, some of it's within the structure of the heart, some of it's out here in the peripheral, some of it is trauma, knowing how to interact with your trauma guys and do from there. All right? Questions?
I was wondering, I'd heard somewhere that a person can only have 3 open heart surgeries in their lifetime. Is that true?
There's a motto that goes beyond that. You can go unlimited times in. Okay. Someone says there's the do, there's the redo, and there's the do-do. Meaning every time you go back in, it gets harder and harder because the anatomy and the planes separate. Become fused together. The first time you get in, no problem. Second time, you can kind of manipulate around the planes and get in. Third time, it's usually much more difficult. But we do that. Well, often we're going back for a third time if they're going for a heart transplant or what we call left ventricular assist device. You're afraid to injure the heart. So going back in the third time creates some injury. But it can be done, it's not often recommended. And with the advent of more structural heart things, these days we can get to without going on the inside of the heart. Any other questions? Ready for lab? Let's go.